The gastrointestinal system. Beginning with the gastrointestinal system, I feel that we need to get just a pretty generalized overview of what constitutes the gastrointestinal system. As we can see here, we begin with the teeth, the tongue, and the salivary glands. And so this constitutes basically the process of mastication, or chewing food and breaking down the particles so that they can be swallowed and then broken down into more manageable pieces, and then further diluted into the stomach. Then we get the pharynx, the epiglottis, and the esophagus, which leads us into the stomach. There should also be a sphincter located right here, which is the cardiac sphincter. And so we have the stomach, and then at the end of the stomach we have the pyloric sphincter, the duodenum. Then we get into the jejunum, and then the ileum, which really isn't labeled here. And then we have this area here, which is the ileocecal valve, or the ileocecal junction, which is the transition point between the ileum and the cecum. Here at this point we do have this structure, which is known as the veriform appendix, or just abbreviated as appendix. And then on the right side we travel up the ascending colon horizontally with the transverse colon, and then down through the descending colon, and ultimately wind up through the rectum and the sigmoid colon, and then culminating at the anus, where the food particles, things that have been broken down and are discarded as waste, where the body really can't use them or has no further need of them, is exited through the body, and the body cleanses itself in this process. And so this is just a really short view of basically the gastrointestinal system, but also we do see that in this diagram we have the liver and the gallbladder, which help to aid in digestion and detoxification of the body, and we'll discuss all of this in further detail later. Here's a larger view of the large intestine. I apologize for the haziness that may actually exist here, but just notice that once again we have several important parts. We have the ileocecal valve here, the appendix here, the cecum, which then leads into the ascending colon. Also take note of what flexures are. As we know, the liver is on the right side and the spleen is on the left side. And if we take that knowledge, we know that the right side then should be called the hepatic flexure, hepatic meaning liver, and the left side is the splenic flexure, because that is where the spleen resides. So connecting these flexures is the transverse colon, which then leads into the descending colon, sigmoid colon, rectum, and then the anus. So the first pathology of the gastrointestinal system that we'll actually discuss is ascites. The word ascites is of the Greek origin ascos and means bag or sac. Ascites describes the condition of pathologic fluid collection within the abdominal cavity. So this is important to remember, that it's pathologic fluid collection in the abdominal cavity. And so that's what ascites denotes. Fluid in the peritoneal cavity originates from many different sources and varies greatly in composition. Healthy men have little or no intraperitoneal fluid, but women may normally have as much as 20 milliliters depending on the phase of their menstrual cycle. And so keep that in mind, that men should have no fluid, no free fluid in the abdominal or pelvic cavity. However, women, depending on their phase of the menstrual cycle, can actually have as much as 20 milliliters of free fluid in the abdominal / pelvic cavity. So this becomes very important in distinguishing what is normal and what is not. And so many times if you find that women have free fluid, then it becomes very necessary to know where they are in regards to their menstrual cycle. And so all of these bits and pieces of information can help us understand whether this is abnormal or normal fluid collection. We must also remember that there are different types of ascites. The first type is exudative ascites, and it's associated with inflammatory processes. And this can be such things as pancreatitis, peritonitis, and bowel perforation. So we see that exudative ascites has a very specific list of things that actually cause it. We also find that we have neoplastic ascites, and as the name implies, neo meaning new growth, and it's caused by intraperitoneal tumor. And so something such as cancer causes the accumulation of fluid. Many times that I've seen people with pancreatic cancer or hepatic cancer actually wind up having tons of ascites, and other diseases as well can actually cause this. Colitis ascites is caused by obstruction or traumatic injury to the thoracic duct or cisterna chili. And so this is very important to know as well, what colitis ascites can actually be caused by. And so just keep those two things that can cause it in mind as well. Okay, so what causes ascites? Ascites represents a state of total body sodium and water excess, but the event that initiates this imbalance is clear. So, as we all know, the higher the amount of sodium that actually exists in the body, it causes water to actually be needed in the body to help balance out the values of the sodium in relationship to the water, and because of that, you pretty much flood the body with water. And so there's three theories of causation here. One being underfilling, where the kidneys aren't able to actually allow and excrete all of the filtration that is existing throughout the bloodstream, and because of this, we actually have underfilling, and so blood has to back up. Overflow, pretty much high sodium intakes cause water to go in. The body cannot get rid of it, and so the body has to put this water somewhere, and so it kind of seeps out and gets into the peritoneal cavity. And peripheral is just other things that can cause it, not really related to underfilling or overflow, but rather some underlying disease that is causing this. So there's a very specific set of symptoms that are usually associated with ascites. Typically signs of liver failure could be present, and that can be jaundice, pulmonary arrhythmia, spider angiomas, or an enlarged liver. Other things that you can look for is elevated jugular venous pressure or a Sister Mary Joseph nodule. The Sister Mary Joseph nodule is actually a bulging in the umbilicus from a palpable nodule, and it's usually associated with metastatic disease in the abdomen or pelvis. However, as we saw, the neoplasm ascites can actually cause this, so you would look for it there. But pretty much a lot of times, something that's not actually wrote here is people have this very, very bloated feeling, this enlarged abdomen. They have swelling that has really just rapidly increased from what they were. I remember one time on a specific patient that I've just performed a CAT scan on here recently. She normally weighed around 111, and over the course of a couple days, she woke up from bed and her weight had ballooned up to 124, and they were giving her Lasix to actually bring her weight back down. But as we did the scan, she had quite a bit of free fluid in her peritoneal cavity or associated ascites. And so typically you see the abdomen become very taut and very just rigid, and to where it hurts. There is quite a bit of rebound when you press on it. And so things like this are what we actually look for in terms of ascites, as far as being able to make a diagnosis without the use of computer tomography. However, computer tomography has really allowed us to see how these symptoms intertwine with what the patient actually has. So depending on the physician that is actually working with the patient, and depending on the patient's body habitus and other things, we'll kind of designate what route is actually taken. We do see that chest x-rays and flat and upright abdominal series provide some type of indication based on what this fluid is actually doing. If we see elevation of the diaphragm, it is indicative of massive ascites. 80% of patients have the Helmer sign, and this is when the lateral liver edge is medially displaced from the thoracico-abdominal wall. And so there's a change in the liver that the radiologist actually look for, and for the attending physicians. Also, ultrasound volumes as little as 5 to 10 milliliters can routinely be visualized. So ultrasound has a very amazing track record for this. However, I want to also say that ultrasound is one of the modalities that is very, very user dependent, and also not all facilities have ultrasound coverage 24 hours a day. And so ultrasound sometimes may not be the clear, obvious choice. And also, if the patient has a large amount of abdominal contents, then sometimes it becomes very detrimental to actually be able to visualize what may be going on. Then we get into CT abdomen pelvis, and we all know that this is a simple examination, very easy, takes very small amounts of time, and is very decisive based on how much fluid there is. We also find that ascites is semi-quantified using the following system. Stage 1 is detectable only after careful examination. So basically, you have to examine the patient, and you have to use other modalities to actually demonstrate the patient's ascites. Stage 2 is easily detectable, but of relatively small volume. And so a lot of times physicians use how they press on the abdomen, how the patient feels, the history of the patient, and other factors to actually see whether the patient has ascites or not. If you have someone who has cirrhosis of the liver, then it's pretty obvious that this person is probably going to have ascites. However, at stage 2, it's only detectable, but you can only find a very small amount. Stage 3 is obvious, but not tense ascites. And what we mean by tense ascites is that the abdomen is just pulled really, really tight, and there's little to no amount of pressure that you can put on it that really will not get the patient and almost jumping off the table. Stage 4 is tense ascites, and that is when you're pressing on the abdomen. There is no give to the abdomen at all. It's very tense, very rigid, and just simply by pressing on the abdomen, the patient will pretty much lift off the table because of the amount of pain that is actually associated here. Okay, on this image, we actually see ascites, and it's a moderate case, not quite as bad as some cases which I have seen, and I'm sure you have seen as well. However, typically when you have very profuse ascites, one thing to actually look for is when you're scanning down and you get into almost the mid-abdomen, maybe even down into the pelvic area. Look around if the patient is kind of a large patient, not really a very tiny patient, look around the posterior portion and look at the fat. And if you see stranding through the fat, that really denotes someone with probably stage 4 ascites. because it's actually seeping out into the subcutaneous fat and actually getting out, trying to break through the skin. So it's very, very important to kind of notice how far this fluid actually progresses. But if we just look at this image, we see that we first have to go over some anatomy so that we can actually understand what we're looking at. So this structure here is the liver. So we're going to put an L here. This is the stomach. And this little organ here is the spleen. And so keep those in mind. And let's erase what we have here and then look at it. Okay, so I'm sure that you all by now have noticed this stuff here. Okay, and so what did we say that ascites really was, or what kind of caused ascites? It's an imbalance of sodium and water. You have too much sodium usually, and your body is retaining fluid. So if we see that that is the case, then we also find that what we're looking at here that I'm just erasing now, that has a very different density. Notice that it's not bright white like what we see the stomach, because it's contrast filled, and it's a little less dense even than the muscle that we have. So we see that this has the density of water. And for those of you who are in the CT class of the physics, we will find that the CT number of water is actually 0. And so in terms of Hounsfield units. So that's something that we can measure, but it's really not important right now because it's pretty obvious that this person has ascites. But one of the great things about being in radiology is that we kind of get to investigate and piece the puzzle together and outside of all the other members of the medical community, because we can actually see the patient and the symptoms, and then we can actually see the scan and see what's actually going on and might be causing this. And so this patient actually has something going on in their liver. We see this huge area here, which looks like either one large mass or several bits and pieces of malignant areas in the liver. And so this is actually causing the liver to cease in its function. And so I would be pretty surprised if this patient didn't present with some jaundice in color and just other problems as well. You'd probably see demonstration of abnormal liver functioning enzymes, things like that. But here we see ascites, and this is caused by a neoplasm. And so this is neoplasmic ascites. This image is actually extending down into the pelvic area. And so we see that we have what looks to be this area here. And this is quite a large amount of free pelvic fluid. And we assume that this is a female because we have the uterus here. And so even just looking at this simply, we see that this is a uterus. And so this female patient has probably more than 20 milliliters of fluid. If you take out a 10 milliliter syringe and you were to fill it up twice and inject it, you wouldn't have a great deal of fluid. And so this is much more than that. Also, something to kind of take notice is that we have a little bit of stranding out here. And so it has reason for us to believe that there is probably an additional amount of fluid on up mid-abdomen, on up into the liver, somewhere around this area. Also, we do have a measurement taken here, and we see that it's 15 Hounsfield units. And remember, I said that water was around 0. However, we do see that there is a deviation here as well, and so potentially we can be off. But we do pretty much understand that this is water here, and it matches some of the other structures in the abdomen, like we have this coming in, which is probably bladder. And so because of that, we see that this matches this. And as we know, urine is mostly water with a few nutrients and waste products mixed in. And so pretty much same density here. So we assume that this is ascites. But it'd be very interesting to be able to look at the upper portion of the scan. So ascites is very, very easy to really distinguish, which now brings us to abscess. And so we see that an intra-abdominal abscess are localized collections of pus that are confined in the peritoneal cavity by an inflammatory barrier. This barrier may include the omentum, inflammatory adhesions, or contiguous viscera. The abscesses usually contain a mixture of aerobic and anaerobic bacteria from the GI tract, and so that's important to know that we have aerobic and anaerobic, meaning that we have some that are oxygen dependent and some that don't really have to have oxygen, and so that becomes very important in the differentiation and what you can do to actually treat these. If untreated, the process continues until the bacteremia develops, which then progresses to generalized sepsis with shock. And septic shock is something or a situation that no one really wants to be in. We've gotten better in the medical field now at understanding when patients are actually going into septic shock. However, septic shock is a very, very dangerous and life-threatening situation, and it's amazing how something simple as an abscess can actually go and progress farther until imminent death actually can occur. And so it's very important to understand and recognize abscesses. So microbiology includes a mixture of aerobic and anaerobic organisms. As we just said, aerobic means oxygen needing or oxygen requiring. Anaerobic means that it doesn't have to have oxygen. The most commonly isolated aerobic organism is Escherichia E. coli or E. coli. And the most commonly observed anaerobic organism is Bacteroides fragilis. A synergistic relationship exists between these organisms. In patients who receive prolonged antibiotic therapy, yeast colonies or a variety of nosocomial pathogens may be recovered from abscess fluids. And so the important thing is that a synergistic relationship exists. A synergistic means, syn means the same. And so basically you can have the aerobic and anaerobic organisms coinciding together and actually working together to harm the patient. And so it's very important that these abscesses actually become very controlled very rapidly, because the patient health can diminish rapidly as well. So what causes an intra-abdominal or an interperitoneal abscess? The most common causes are perforation of a diseased viscus, perforated appendicitis and diverticulitis, gangrenous cholecystitis, mesenteric ischemia with bowel infarction, and pancreatitis or pancreatic necrosis. And so I know that there are a lot of big, huge words here. And so basically let's just look at this bullet point by bullet point. Perforation of a diseased viscus. So you have at some point in time a diseased portion of the colon, and this colon actually ruptures, and the abdominal contents spill out, and then before things are cleaned up, before perhaps anything is actually realized, it starts setting up an abscess. We also see perforation of an appendix or diverticulitis. And so diverticular disease is very important. It can lead to many different things. Sometimes it can lead to fistulas between the bladder and the diverticular diseased portion of the colon. But other times the diverticular diseased portion actually ruptures and then just allows the abdominal contents to spill out. And because of that, the body has to fight whatever bacteria is existing in the colon at the time. And sometimes if you have a weakened immunity, if you have anything, the body is just not able to fight this off. And the same goes for perforation of appendix. That can be one of the nastiest, deadliest things that can happen, because appendicitis tends to be, or true cases of appendicitis are sometimes not as common as what we think they are. However, I see many patients who completely ignore the symptoms of appendicitis to where they don't want to take off of work, they don't want to do anything, they don't even want to go to the doctor, and they get to the point to where they're so miserable that they have to go. There's no other way that they can survive, and when they do, they find out that they've had a ruptured appendix for several hours or days. And because of it, it has actually set up an inflammation in the abdominal cavity. And so things become much more deadly. Appendicitis in itself is not quite as deadly as what can lead after the ruptured or perforated appendix. The gangrenous cholecystitis. And so you have a gallbladder that just pretty much shuts itself down, but is never taken out. And so it just sets up inflammation, and there we go with it. Mesenteric ischemia with bowel infarction. And so basically you have something go on in terms of the bowel, and so it causes a portion of the bowel to actually die. This can be such things as strangulation, anything where the blood flow is actually stopped. And when we hear infarction, it's just the same manner as a myocardial infarction, where a portion of the heart doesn't receive blood, and that portion of the heart dies simply because of not being able to have the oxygenated blood. And it's the same with the bowel. The bowel actually dies, and the patient should be in tremendous pain and should be able to recognize this. But in the event that they don't, and this happens, then inflammation can actually set up. And then we get to pancreatitis or pancreatic necrosis. We'll cover pancreatitis in further lectures and see how this kind of works out. But we do see that pancreatitis and the inflammation that actually goes on there can lead to an intra-abdominal abscess as well. So hopefully that provides some degree of clarification here on what causes an abscess. So what are the symptoms of an abscess? We would think that it'd be pretty obvious. You'd have tons of abdominal pain. You'd be pretty much writhing in pain on the stretcher. And there'd just be a red flashing light that says, I've got an abscess. But most patients tend to ignore this stuff. So you have persistent abdominal pain, which a lot of people kind of chalk it up to, if we're in the middle of flu season like we are right now, they chalk it up to either having a cold virus or the flu. And they don't really think anything about it until it just continues going on. Also, we have focal tenderness. So at one spot in the abdomen, you can press and the patient just has tons of pain there. Spiking fever. So basically you have a fever that just goes up will not come down. And this is because of the inflammatory processes that are going on through the body. As we know, a fever is just a relationship of the body attempting to fight off an inflammation. And many times it's important to allow the fever to go on. Well, a lot of patients actually mistake what they're having with abdominal pain and a fever as being just a cold or a virus. And actually, it's until the fever just refuses to come down will it actually be defined as something longer or more. Prolonged ileus. I think we all know what an ileus is, and so an ileus that just refuses to be resolved. Leukocytosis, increased amount of white blood cells. Mild liver dysfunction or persistent GI dysfunction. So pretty much you have abnormal liver enzymes indicating that the liver is not functioning properly, or you have persistent GI dysfunction, meaning that you're eating things should be going okay, but they're not, and so you have tons of problems anytime that you consume food or you drink things like that. You have an associated increase with pain, discomfort, things like that. Can all be indicative of an abscess. So the way that we find out whether the patient has an abscess can be simple as this: lab work, and you see CBC, you do a CBC, and you look for white blood cell elevation coupled with neutrophils, eosinophils, monocytes, things like that are elevated. Abdominal films are very rarely diagnostic in nature. You might be able to see something like an ileus, which will lead you down a pathway. However, highly unlikely that you're actually going to be able to see an abscess on an abdominal film. Ultrasound has an accuracy rate of 90% or greater, which sounds pretty great. And we do see that several places do have ultrasound. It is in your smaller hospitals that you don't actually have ultrasound coverage 24/7. And because of this, ultrasound kind of is not the gold standard for looking at an abscess. But ultrasound does have several things going for it. It's readily available, it's portable, you can take it to the patient's room, and it's very inexpensive. Exams are very much less costly all the way around for the hospital as well as for the patient. However, it's very operator dependent, and so not necessarily are two exams always going to be equal. It's going to be very much dependent on what the person performing the procedure actually can do. That brings us to CT abdomen pelvis. Usually this can be performed without contrast. Many times it's performed with IV contrast if you're specifically looking for an abscess so that you can see the uptake of contrast, iodinated contrast throughout the inflammation. And so it's sometimes depending on the physicians will either favor without or IV only. But the important thing to look at here is that CT has an accuracy rate of around 95% or greater. And so that means that there are only a very few times that CT does not do a good job of picking out an abscess. One thing that I have to come back to is if you are doing a CT for an abscess, then you have to be mindful of what could be causing that abscess. And as we see, we do have a lot of perforations and tears in the abdominal area that can lead to an abscess, such as an appendix rupture or diverticular disease or viscous tear, things like that. And so just want to make it known that it's very important that we use water-soluble iodinated contrast, such as Gastric and things like that, for oral contrast if we are instructed to give oral contrast to aid in the diagnostic quality. If we are, it becomes very important because barium, while barium does an excellent job of pretty much being able to distinguish bowel from other parts of the body, and does help and aid very much in our diagnosis, and it's very much cheaper than the water-soluble iodinated contrast. We do see that barium has a greater tendency to be very harmful when it actually gets into the peritoneal cavity, and so we don't want to set up another abscess or further this inflammation or inflammatory process because of the contrast that we've had them drink. So it's very important that we use water soluble, not barium, in case of a perforation, especially when we're looking for an abscess, because we don't know what might be causing it. So looking at it from CT, from a standpoint, we see that an abscess typically appears as a localized fluid collection of around 10 to 40 Hounsfield units in attenuation. So as we saw with the Ascites, and we had 15, if we took a measurement of this, should be around 10 to 40 Hounsfield units, and I would favor more along the lines of the 40. So look for an Hounsfield unit around 40 for an abscess. And developing abscesses may resemble encapsulated ascitic fluid. And so what we mean by this is that it may almost look like fluid or free fluid, but it's going to be encapsulated, meaning that there's going to be a barrier that's keeping whatever this fluid is from actually being free. Often has internal debris, fluid levels, septations, and even air fluid levels. And so the big thing to look for here is air fluid levels. And we'll actually see that in some of our images here. That's one of the things that we can really look for. So look for air fluid levels. Once again, the air can be generated from the bacteremia that are actually causing this abscess. So they can produce some degree of air, and because of this, we can actually see the abscess better. We also look for a definable wall with irregular thickening, and so you look for something that has a wall around it, but the wall is not always the same. And so we may have a wall here, and notice how the wall is not the same. It's thicker here and very thin here. And so this would be something that we're looking for. And we also see that abscesses are often associated with ascites, pleural effusions, and lower lobe pulmonary infiltrates. And so if we see any of these things, then it's still possible that we could see an abscess as well. So keep that in mind, but also keep that we're looking for around 40 Hounsfield units for the measurements, and we're looking for air fluid levels, or another thing that we are looking for is septations. And so you're going to see probably a lot of your abscesses actually bear this out. Okay, so let's take a look at this image. As we can see, we're at the level, we're past the iliac crest. We're going through the pelvic cavity right now. We do have the psoas muscles here and here, so I want you to keep that in mind, the psoas muscles, so that you don't actually get it confused with an abscess or think that it's something else. And we do have bowel contrast, and we hypothetically must conclude that based on the way that this bowel actually looks, we have passed the jejunum, and we're still in the small intestine, but it's probably around the ileum. And the reason I say that is based on the location of the abscess. As you've probably already picked out, here is the abscess. It's pretty nasty looking, and something that really is kind of concerning is if we'll notice here, it almost looks like it goes into it. And so if this is the case, then it's probably around the ileocecal valve, and what we find that's attached to the ileocecal valve in the cecum is the veriform appendix. And so this could potentially be an appendix that has actually ruptured and caused all kinds of havoc down in the right lower quadrant. But another thing to look for here, we do have these lines coming off on the posterior portion here, and that's just kind of points of attachment, and it's kind of streaking. That's indicative of an inflammation or an inflammatory process. Also, we must take a look at the margins here. We have irregular margins. This side is thick, whereas this side is very thin. And we do see that we have basically fluid on fluid levels. We have something here, and then we have something here. And so we do have two different layers here. And so all of this combined leads us to believe that this is an inflammation. We would also not just take CT's word for it, even though we would have a 95% accuracy rate here or greater. We'd also look at elevated Y counts, things that would be indicative of an inflammatory process in the abdomen. Here is another abscess. We must also take notice of our location again. We've got iliac crest coming in here. And this one is very definable, not that hard to actually distinguish. We have this area here, and notice how the wall is very irregular. You have thick wall, very thin here. But I also want you to take notice of where the arrows are actually pointing here. There is air fluid level. We know that this is air because one of the great things about the scanner is that the patient doesn't usually always fill up our scan field of view. And at this point, we see that where the red arrow is pointing is what air looks like on CT. It has no density whatsoever. And we see that air here has no density as well, even inside the body. And so the air is where the line is pointing, and presumably there is an air fluid level. And so it would be very difficult to actually miss this. But also, we must take a look at the surrounding structure here. If you'll see these little bitty wavy lines coming out, kind of just adds to the viciousness of this abscess. And so that is inflammatory processes as well, kind of extending out. We don't really know what the cause is here. We're on the left side, not the right side. And so we would typically really have no idea what is causing this. Possibly it would be a tear in the intestines or perforation that has actually caused this based on the location. However, we do see that this is an abscess, and this is a very, very classic case of what an abscess would actually look like. Okay, here is the previous patient. It's the same patient, but here we see that the abscess is just coming in. And so based on the location here, we see that there's a point of attachment with the bowel here, and there is what looks to be a little bit of free air here, and it's possible that once again this is a rupture of the intestines. But also notice here that we don't really see much of a border around it, but we do see the levels, and the levels are what gives it away, because you should not be seeing levels like this. And also this process here and this haziness here. And so that would be what we call debris. So diverticulosis and diverticulitis. This describes small sac-like outpouchings of mucosa and submucosa through the muscular layers of the wall of the colon. It represents acquired herniations of mucosa and submucosa through the muscular layers at points of weakness in the bowel wall. Incidences increase with age, with it being rare in people under the age of 30. So keep that in mind, that typically it's going to be very rare for people under the age of 30 to have diverticulosis, diverticulitis. If the neck of the diverticulum becomes obstructed with feces or undigested food particles, or even an inflammation, diverticulitis results. This inflammation can then spread to adjacent diverticula, having the ability to affect both long and short portions of the colon. And so the thing to remember here is what actually causes diverticulosis and what leads to diverticulitis. When I was doing my undergraduate work at Eastern, one of the things that was told to us was that diverticulosis can potentially be caused by when patients or people strain when having a bowel movement. It actually causes these herniations to occur because the bowel at certain points in time becomes weak and can have weak areas in it, and all you need is the right amount of pressure to be exerted in the bowels to actually cause these little herniations. And so what we have here is something that looks something like this, to where you have normal segments here and you have abnormal segments here, caused by amount of pressure being passed through the bowels. And so it's these little outpouchings that are indicative of diverticulosis. And so a lot of people get diverticulosis and diverticulitis confused. To have diverticulitis, you must first have diverticulosis. And this is because you have to have diverticulum. And the diverticulum actually becomes obstructed. And when the obstruction occurs, it just kind of stays in there and irritates and irritates and irritates. And it inflames this little bitty outpouching. And as it inflames, then we have an inflammation, an inflammatory process, and so that is diverticulitis. And as we see here, this one small spot of diverticulitis can then spread throughout all the diverticuli and cause tremendous amounts of pain. And that's why many people associate diverticular disease with being pretty painful at some points in time, depending on what stage you're in. So as we've already discussed, what is thought to be the cause of diverticulosis is the high pressure exerted in the lumen while straining to pass a large bulk of stool. And so once again, this high pressure that's exerted into the intestines actually causes these ballooning or outpouchings. And so that's why patients who have a great deal of difficulty using the bathroom, having a bowel movement, usually are the ones that will be having diverticular disease. So, the symptoms of diverticular disease. Many times patients have no symptoms, while sometimes others exhibit these. Intermittent low abdominal pain, frequently worse after eating or when stressed, and alternating bouts of diarrhea and constipation. And so this alternating bouts is usually what people associate with diverticular disease. Sometimes patients feel like they can't have a bowel movement, and then potentially the next day they can't control their bowels. And so alternating bouts like this are quite normal and quite indicative of diverticular disease. Also, we must say that this intermittent low abdominal pain and frequently worse after eating or when stressed is really indicative of diverticulitis. It's really indicative of that because you're inflaming this process, and when it's inflamed, then you have tons of pain. And depending on what you do and how you do it, can actually lead to more or less pain. So the workup for diagnosis. We begin with a lab test, CBC, metabolic panel, urinalysis, and blood cultures. CBC helps demonstrate an elevated white blood count and other inflammatory processes that may cause spikes in values. Metabolic panel just kind of gives us an indication of if there could be some other abnormality going on that we're not focusing on because we're getting focused on something else. urinalysis to rule out urinary tract infection, and also renal stones, because sometimes renal stones can mimic the pain of diverticulitis. And then lastly is blood culture, and helps to rule out septicemia. And so that is your blood becoming septic. And so it's very important to rule out sepsis in this case as well, because we saw that diverticular disease can actually lead to abscesses, and then abscesses can lead to septic shock. We also do have the opportunity to utilize CT, such as abdomen and pelvis, MRI, small bowel follow-through, or abbreviated as SBFT, barium enema, EGD, and colonoscopy. And so the real question is here, what do physicians really want? And as we see, it's very dependent on their background and how comfortable they are and how open they are to new types of exams. Many rely on small bowel follow-throughs to actually provide some indication of what the small intestine looks like. But as we see, most of diverticular disease actually occurs in the lower portion of the large intestine. And so many times small bowel follow-through will not actually help beyond the ileocecal valve. MRI sometimes takes too long, and patients are not able to hold still for an extended amount of time. Barium enema is highly invasive and highly problematic for some patients to actually overcome this feeling, this dread that actually occurs with it. And so in some institutions, barium enemas have still kind of kept its vaulted position as being a go-to exam to kind of look at this stuff. However, in many instances, barium enemas are viewed as not quite as adequate as things such as colonoscopy, and only barium enemas are relied to after colonoscopy has been exhausted. And so colonoscopy is usually a very excellent way to actually distinguish diverticular disease, because what it allows you to do is, while you have the camera inside the patient, you can take biopsies, you can look at other things, and so it provides a more rounded picture. But I would also argue that CT does allow you to do this as well if proper amounts of contrast are given. And I know some radiologists favor rectal contrast when you're looking for diverticular disease. Also, we must be sure, once again, that it is water-soluble contrast, because any diverticular perforation can actually be very detrimental to the patient. However, colonoscopy, once again, is much better than the other exams listed here, simply because it allows you to not only be diagnostic, but it also allows you to have a better diagnosis because of the biopsies and things like that. So colonoscopy still remains the favorite for many physicians. So what does it look like on CT? Diverticula are easily visualized on CT as small, rounded collections of air, feces, or contrast material outside the lumen of the colon. And it ranges in size from 1 millimeter to 2 centimeters. And thickening of the muscular wall of the colon is common. And so acute diverticulitis is demonstrated as a colon segment with wall thickening, hyperemic contrast enhancement, inflammatory changes that extend into the pericolic fat. And so it looks almost like an abscess with diverticular disease portions in it. And so I just wanted to make note of what we're talking about when we have the lumen. And so let me put a crude drawing up here. And so this applies for like arteries, veins, even the bowel. when we talk about a lumen, when we mean lumen, we mean inside the walls or normal boundaries. And so we would all agree that this is pretty much a normal lumen here. It's very straight. There's not much problems here. However, when we have diverticular disease, and we have these weak spots in the lumen, we actually get these outpouchings like this. So where a normal lumen exists here, we would say that this is not normal. And so we have to define these areas as diverticular processes, and this is diverticulosis. And so everything seems to be okay. We know that we'll have food and things like that actually get trapped in these, and hopefully everything will still continue going through like this. And so hopefully you'll have everything pretty much emptied out. And so there won't be anything left behind, lagging behind here. However, the question then becomes, what if your bowels don't move and things get in here and potentially the contents become very hard because you're completely constipated and there is nothing actually leaving the intestines, and the stool becomes hard and this becomes trapped here by the other contents of the bowel. Then inflammation can actually set up and cause inflammation here, which then leads to inflammation here and can cause these other diverticular processes to become inflamed too. And so it all hinges around the normal lumen and then the diverticular diseased portion. So that's very important to understand and in relationship to what our images will look. Okay, on this image we actually do see several bits of diverticular disease, diverticulosis. We're not really sure if it's diverticulitis. We'd have to look further at the patient's symptoms. But this area here is very indicative of diverticular disease. As we can see, we have a outpouching. And in this outpouching, we do see that we have something air, the way it looks, actually in this area. But also in this red circle, we do see some outpouchings there, and it just looks very tiny. And we see the normal lumen here, and here, and here, and here, but we see that there is an abnormal section where the red arrow is pointing. Also, one thing to look at in this image as well is what looks to be dilated portions of the bowel here. It looks kind of dilated. I don't know whether that's simply the jejunum and the feathery appearance that it has, or if that's dilation. But it would be very interesting to actually see what might actually be going on there. This image appears to be diverticulitis. And the reason that I say this is outside of the red circle into the red circle that I just drew, it looks like the bowel wall has become very thick, indicative of inflammation. And we do see that we have little small outpouchings here, which are outside of the normal lumen, and so that is diverticular disease. but not as impressive as some that I'm sure we have each seen throughout our time in clinicals. Small bowel obstruction. A small bowel obstruction, or SBO, is caused by a variety of pathological processes. The leading cause of small bowel obstruction in industrialized countries is postoperative adhesions, around 60%, followed by malignancy, Crohn's disease, and hernias. However, some studies have reported Crohn's disease as a greater etiological factor than neoplasm. One study from Canada reported a higher frequency of small bowel obstruction after colorectal surgery, followed by gynecological surgery, hernia repair, and appendectomy. So small bowel obstruction leads to proximal dilatation of the intestine due to accumulation of the GI secretions and swallowed air. It causes cell secretory activity, resulting in more fluid accumulation. Leads to peristalsis above and below the obstruction. So the thing that you really need to keep in mind here is that most are caused by postoperative adhesions. So the greatest amount of small bowel obstructions are simply a result of scar tissue, things like that, actually causing obstructions. Another thing to keep in mind is that it leads to proximal dilatation, and what we mean is dilation here. Dilatation and dilation are virtually the same words, and when we have proximal dilation, it means that above the small bowel obstruction, you're going to see the small intestine actually dilated. It's going to become larger than what it normally would. It's going to look dilated. And so those are going to be the things that we're going to look for as we continue on. So types of small bowel obstruction. We have partial, complete, simple, and strangulated. Partial means that the patient appears obstipated or severe constipated and continues to pass some gas or stool. So you don't have the full intestinal blockage or obstruction here, so you still continue to allow small bits of passage through. Complete means that the patient fails to pass stool or flatus, and so basically there's nothing that the patient can get out. And another thing to look for with small bowel obstructions and even large bowel obstruction is if you have air in the rectum. If you don't have air in the rectum, then chances are you've got a complete obstruction somewhere. Simple and then strangulated. Strangulated is the one that we worry about the most, because if it's left untreated, it will progress to perforation, peritonitis, and death. So basically, the obstruction is so complete that it starts causing the bowel to actually intertwine on itself and cutting parts of the bowel off, and also damaging the blood supply. So very dangerous. We need to actually watch out for strangulated bowel. So what causes small bowel obstruction? The most common cause of small bowel obstruction is post-surgical adhesions. On the last one we saw that it was, last two slides, we saw that it was 60%, and some other studies say that it's 75%. So we're going to say that it actual cause is around 75 to 65. And so somewhere in this vicinity, we're going to say is where small bowel obstructions actually lie. Also, external hernias are the second most common cause. Other causes include luminal occlusion, intrinsic lesion of the bowel wall. And this is very interesting because this study says that external hernias are the second most common cause, whereas Crohn's disease and malignancies were considered the second and third cause previously. And so we're really not going to focus on what the second, third cause is. We just want to know that the most common cause is surgical adhesions, and then we have a host of other things that can cause it as well. So the symptoms of bowel obstruction, or small bowel obstruction in particular. Number one is abdominal pain, usually cramping and intermittent. It's more prevalent in a simple obstruction. And so it kind of comes and it kind of goes and kind of makes you think that you've got a stomach virus or something like that. Proximal obstruction, you have pain for a short duration with bilious vomiting. Distal obstruction, pain that lasts for several days with abdominal distension. And other symptoms are nausea, vomiting, diarrhea, constipation, fever, and tachycardia. And the bad thing about small bowel obstructions is, if we really look at the symptoms, many of the times it mirrors things such as a virus. And so many times people chalk this up to having a virus or something like that and don't really adhere to the dire situation that it could be. And so sometimes it can also be too late before the patient actually arrives and intervention can be performed. So the workup for diagnosis. Number one is lab test. We do a CBC, which looks for increases in white blood cell count. And this can be indicative of a simple or strangulated obstruction. A metabolic panel is pretty indicative of dehydration and the patient not being able to consume fluid, or a lot of that fluid not getting where it needs to be. Then we do abdominal films, as I'm sure we all have previously done before. The interesting thing about abdominal films, though, is that it has a failure rate of around 30%. So on up to 30% of the patients that potentially do have small bowel obstruction, it goes undiagnosed from abdominal films. And the bad thing about abdominal films is it cannot differentiate strangulation from simple obstruction. So you may actually see an obstruction, but you may not be able to tell whether it's strangulated or just a very simple obstruction. Ultrasound, it's less costly than CT and may reliably exclude small bowel obstruction in as many as 89% of the patients. So notice that ultrasound has about an 89% accuracy rate. However, this kind of pales in comparison to CT of the abdomen and pelvis, which has a 90 to 95% effective rate in diagnosis of small bowel obstruction. And so we can see around 90 to 95% of all the small bowel obstructions. So it's very, very indicative of what's going on. Also, we have a 47 to 74% effective rate in demonstrating causation. So many times, not only do we find that there is a small bowel obstruction, but we also find that we have a cause for it. And so that's very, very essential in actually treating the small bowel obstruction. And then we have MRI, which, as we all know, requires a longer exam period than CT and ultrasound. And so in the case of this, CT having a very high accuracy rate, many times it's just indicative just to go in and perform a CT and let that be the ruling out factor for small bowel obstruction. So what does small bowel obstruction actually look like on CT? First, we begin by saying that intravenous contrast is recommended because it provides enhancement of the bowel wall and better visualization of pathological processes. However, intravenous contrast is not absolutely required to diagnose small bowel obstruction. I've had several patients with small bowel obstructions that I performed CTs on that haven't had any IV contrast or oral contrast either. And they've been able to diagnose a small bowel obstruction simply due to the dilated loops of bowel, and actually based on the patient's history of surgical intervention and things like that. Demonstrations, though, we have a complete mechanical, which appears as a dilatation of proximal small bowel with a distinct transition zone to collapsed distal bowel. So in a complete mechanical obstruction, what you're going to look for is a dilated bowel loops, and then there being a zone to where it actually becomes normal collapsed bowel loops. Paralytic ileus appears as a dilatation of both proximal and distal small bowel, but without a transition zone. Partial mechanical, the proximal bowel is less dilated and the transition zone is less distinct. And so a partial mechanical is almost like a complete mechanical, with the exception that the bowel just doesn't get as dilated as it would with a complete. And then a closed loop obstruction, the beak or whorl sign. And so we'll actually go over that in just a second. So the beak sign in a closed loop obstruction is basically a tapering of the bowel as it leads into the obstruction. And so, just like a beak starts out very wide and then becomes very narrow, that is how the beak sign would look. The whorl sign is a little different. It's due to the twisting of the mesentery. And so there's really no great images to show you on this. Just it kind of looks like a swirl. And that's what we look for. So here we have an example of what a small bowel obstruction actually looks like on CT. And the reason we presume it to be a small bowel obstruction is that we have dilated bowel loops here, 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 and here. And so each of these bowel loops are very dilated. And we notice we have really what looks to be a lot of just fluid. There isn't a lot of fecal material here mingled with a lot of air. And so that kind of correlates very well with what we had previously talked about with many small bowel obstruction getting dilated simply because of the gastric secretions and the amount of air that you inhale that actually travels down the esophagus. And so we can presume that this is a small bowel obstruction, and we really don't see the causation of the obstruction. However, we do have some interesting stuff here, which presumably could be some type of surgical adhesion. However, we don't have additional images on this patient, so it's unknown really what it could be causing. But keep in mind, this is typically what a small bowel obstruction looks like. This image is much the same, and we do see that we have dilation here all around, and very interesting when we do have what looks to be some type of oral contrast here. And so we really don't know what could be causing this obstruction, but we do know that the bowel is very dilated, and there's really not a bunch of fecal material there. And so that's typically what we're going to look for a small bowel obstruction, being no real fecal material, but mostly air and something that resembles the density of water. And here we don't really have a transition point or anything. We have less dilated bowel here. However, we're not really sure where it's leading into. It would prove very interesting to actually see the rest of this study, because it appears like we have IV contrast due to the highlight of the kidneys. The patient has a dilated renal pelvis, which makes us think that there's probably a renal stone at some point in time in the lower portion of the right ureter. But we do have oral contrast as well, and we're just not really sure of what's going on with this patient. So large bowel obstruction. Large bowel obstruction, or LBO, is an emergency condition that requires early detection and intervention. It simply is defined as an interruption of the flow of intestinal contents. The challenges in managing this condition are distinguishing colonic obstruction from ileus, ruling out non-surgical causes, and determining the best surgical management. It's most common in elderly individuals due to the greater prevalence of neoplasm in this age group. And so basically this last line here really demonstrates what we're going to be looking at or looking for as the causation of large bowel obstruction, and that is a neoplasm. It seems to greatly be age dependent, with incidences increasing with age. Mechanical large bowel obstruction causes dilatation above the obstruction, and it equals impaired venous and arterial blood flow to the bowel. LBOs tend to be less acute than small bowel obstructions. So as we see, the small bowel obstructions, we have the potential for strangulation, and it seems to be less prevalent among large bowel obstructions because there is some great underlying cause that is existing inside of the colon. And so many times small bowel obstructions are the ones that require immediate surgical care, whereas large bowel obstructions do require intervention, but the situations are not usually as dire. The symptoms develop more slowly for large bowel obstructions as well, and there's fewer fluid and electrolyte disturbances that are produced. And so basically, it's harder to diagnose large bowel obstructions because there's less symptoms for it. And so we see that increases the difficulty and need for accurate diagnosis. 70% of large bowel obstructions are caused by primary colonic carcinomas. Diverticulitis and volvulus account for most other cases. But keep in mind, though, that 70% are caused by primary colonic carcinomas. And so basically, intestinal cancer actually causes many of these large bowel obstructions. So the symptoms of large bowel obstruction. While symptoms can vary greatly, some of the more widely noted are abdominal distension, nausea, vomiting, cramps in the abdomen, and history of carcinoma of the colon. The last point here, the history of carcinoma of the colon, is almost a dead giveaway if the patient is experiencing other symptoms. Because if you have a history of carcinoma in the colon, then it becomes almost assured that you could have a carcinoma that's causing an apple core lesion, restricting the flow of bowel contents. So how do we actually diagnose large bowel obstruction? Number one, we have lab tests such as CBC, metabolic panels, urinalysis, and I'd also like to throw another one in that is not on the slideshow, and that is lactate. Lactate, I've been told by several physicians, is very indicative of a bowel perforation, which can be due to any type of obstruction. And so typically you'll see a lot of physicians order lactate as well, just to see what's going on with the patient. But in terms of the CBC, we should see a decreased hematocrit level, which can be indicative of possible lower GI bleed, white blood cell count, substantial leukocytosis, could mean ileus or infection. And so we look for these things to actually demonstrate maybe a large bowel obstruction. A metabolic panel is indicative, once again, of dehydration, and urine or urinalysis is looking for some other causation of the lower abdominal pain, lower pelvic pain, which could typically be associated with renal stone. And so if a patient has a history of renal stones, then it becomes necessary to actually look and see whether there is a renal stone there as well. Chest x-ray and abdominal flattened upper right. We should see dilated colon without air in the rectum, which equals obstruction. And so that's typically what we're looking for, is without air in the rectum. If there's no air in the rectum, then we know that we've probably got an obstruction somewhere if the symptoms fit. Free air is something that we never want to see. And it's basically indicative of a perforation, which can be very deadly to the patient. CT abdomen pelvis is not useful in patients with large bowel obstruction unless the diagnosis is still in question. So as we see here, we should see that the abdominal flattened upright films with the chest x-ray should be adequate for diagnosis of the large bowel obstruction. And so CT doesn't really play as a prominent role as other things. However, some professionals recommend a scan for patients without a history of surgery who have symptomatic signs suggesting infection, bowel infarction, or a palpable mass. And so there are physicians out there that say that you should just scan the patient just as kind of a catch-all procedure, so that you rule out any other extenuating factors that could be contributing to this pain, and you can actually see what might be causing this. Another thing is endoscopy. Endoscopy tends to be a very favorable result here, because it allows you to see what might be causing this large bowel obstruction, and as we saw before, 70% of the cases are typically revolving around primary carcinoma of the colon. And so if that is the case, then endoscopy really provides an accurate and adequate means of finding out what's going on there. Because CT is generally not utilized for large bowel obstruction as a primary means of diagnosis, it is relegated to use if the diagnosis is in question. This means that many times the causation of the obstruction will be found instead of the obstruction itself in CT. And so that's an important thing to keep in mind, is that typically we're not even looking for a large bowel obstruction, we're looking for the causation or what might be causing these symptoms. And so if the person has a primary carcinoma of the colon, then that's typically what we're looking for. We're not actually looking for the large bowel obstruction, but rather what is causing it. Here is a really indicative large bowel obstruction. I think it's highly obvious. We're at the ascending colon here. Oh, let me erase that and get down to a more defined here. And we're looking at this entire area here. And the very interesting thing about this area is if I erase all of this, we see that we have what looks to be something here. And based on the location, we probably are going to presume that this is the ileocecal valve, where we're crossing over from the ileum to the cecum, because it looks like we do have maybe the appendix in this area too. But we do see that this is probably an obstruction where we're not actually seeing the obstruction, because the obstruction is probably somewhere around the transverse colon, and we're seeing the proximal portion dilated, whereas we're not seeing the distal portion. We could actually have a carcinoma residing in the distal portion, which we would define as the descending colon, and that could be causing this. Also, we don't have enough images to where we can actually see if there's air in the rectum or not. We're only seeing the bladder, and so we're not actually able to see this. So additional imaging would be required. However, if we were performing the CT, we would have the option of being able to scroll through the images, and that would become very beneficial for us. So that brings us to one of the most commonly viewed or sought after reasons for doing CT ever, and that is appendicitis. Appendicitis is defined as an inflammation of the inner lining of the variform appendix, or we'll abbreviate that to just appendix, that spreads to the other parts. It develops with the neck of the appendix when the neck of the appendix becomes blocked by a fecalith or post-inflammatory scarring that creates a closed loop obstruction within the organ. And so that's important to keep in mind, that appendicitis actually begins with a closed loop obstruction and then progresses from there. Despite diagnostic and therapeutic advancement in medicine, appendicitis remains a clinical emergency and is one of the most common causes for acute abdominal pain. Appendicitis is one of the more common surgical emergencies, and it is one of the most common causes of abdominal pain. In the United States, there are around 250,000 cases of appendicitis each year, representing 1 million patient days of admission. And so, if we look at this, these 250,000 cases are averaging around 4 days of admission per patient based on appendicitis. Appendicitis occurs in 7% of the population, with an incidence of 1.1 cases per 1,000 people per year. So this simply means that out of 1,000 people, one of those people are actually going to have appendicitis in the year. We do find several things interesting about appendicitis, though. We see that it's lower in cultures that have a high fiber diet, which increases the viscosity of feces, decreases bowel transit time, and discourages formation of fecaliths. So there is some prevalence to think that a high fiber diet might actually help to decrease the amount of appendicitis cases that we see. The median age at appendectomy is around 22 years old. That's not to say that if you have passed 22 years old that you don't have to worry about it, because appendicitis can be prevalent, can occur in almost any age of people. However, we do see that it starts flaring up usually around 22 years of age, but that is no wise inclusive. But the interesting thing here is that there is only 250,000 cases a year of appendicitis. So that also means that everyone that you do that has had an abdominal pain does not have appendicitis. In the facility that I work, we have a lot of cases where the patients feel that they have appendicitis. They're almost assured that they do, and then we get in there and there's actually really nothing wrong with their appendix at all. The appendix is within normal limits. And so just because you're having and experiencing abdominal pain is not necessarily indicative of appendicitis. There's other factors that we have to mitigate as well. Statistics report that 1 of 5 cases of appendicitis is misdiagnosed. And a normal appendix is found in 15 to 40% of patients who have an emergency appendectomy. And so keep this in mind, that 15 to 40% of patients, of all patients who have emergency appendectomy, to where the appendix has got to come out at this moment. We've got to get the on-call physician, get them in here so that we can get this thing removed. Typically about 15 to 40% have a normal appendix. But the question is, you are going to remove that appendix while you're in there, because if you got the patient opened up, if you're doing laparoscopic appendectomies, you're still inside the patient, and so you might as well go ahead and remove the appendix while you're in there, because at some point in time the appendix could flare up and actually be a legitimate case of appendicitis. However, it's just ironic to look at that. If we favor the middle ground here, around 30% is completely misdiagnosed. So that's very interesting here. The most common causes of luminal obstruction include a lymphoid hyperplasia secondary to inflammatory bowel disease. It's common in childhood and young adults. Fecal stasis and fecaliths, which are indicative of elderly patients. Fecaliths form when calcium salts and fecal debris become layered around a nidus of fecal material located in the appendix. And so basically when we have fecal stasis, constipated for a long amount of time, bowels are not moving, and because of that, there's actually accumulation of fecal material actually pushed out into the appendix, which hardens and causes an obstruction. We also see that parasites can cause appendicitis, but the most common causes are just inflammatory bowel disease in children and young adults, and fecal stasis and fecaliths in older adults. So what are the symptoms of appendicitis? The classic history of anorexia and paraumbilical pain, followed by nausea, right lower quadrant pain, and vomiting, occur only in 50% of the cases. Nausea is present in 61 to 92%. Anorexia is present in 74 to 78%. Vomiting that precedes pain is suggestive of intestinal obstruction. And so one of the things that we come back to is vomiting. I've had a general surgeon tell me that vomiting really doesn't occur in cases of appendicitis. Typically, if vomiting is occurring, then that the pain that's associated or what they're feeling is actually coming from something else. So highly unlikely that vomiting will actually occur. But we do see that anorexia is very present in about 74 to 78% of the patients, simply because they refuse to eat. Nausea is present, And remember, nausea is different than vomiting. Nausea is the sensation where you feel very sick to your stomach. Vomiting is actually when the food actually comes up. So patients will feel nauseated, and a lot of the times that's associated with the pain. And as the pain increases, the nausea increases as well. The most common symptom of appendicitis is abdominal pain, and not just any abdominal pain, but it's usually in the right lower quadrant. Symptoms begin as paraumbilical or epigastric pain migrating to the right lower quadrant. Patients usually lie down, flex their hips, and draw their knees up to reduce movements and to avoid worsening their pain. And so typically you see patients that actually almost get into a type of fetal position to where somehow this lessens the pain, and they refuse to move from this. Also, the duration of symptoms is less than 48 hours in approximately 80% of adults, but tends to be longer in elderly persons and in those with perforation. And so the real thing about appendicitis is if you have right lower quadrant pain that just ceases to give up, then chances are you're on your way to getting a perforated appendix. So it's very, very important that we actually get an accurate diagnosis on this. So lab test. CBC studies consistently show that 80 to 85% of adults with appendicitis have an elevated white blood cell count greater than 10,500. And this is due to the inflammation in the body attempting to fight this off. Less than 4% of patients with appendicitis have a white blood cell count less than 10,500. So it's very, very likely that you're going to experience a white blood cell count increase. Also, C-reactive protein, which is an acute phase reactant synthesized by the liver in response to an infection and inflammation, and rapidly increases within the first 12 hours. The bad thing about the C-reactive protein is this: it cannot distinguish between sites of infection. So you could have such things as colitis, diverticulitis, which are also inflammations, and it cannot distinguish between each of these inflammatory processes. So as we'll see, that Crohn's disease and colitis can mirror the symptoms of appendicitis and other things. And so if that's the case, then C-reactive protein kind of goes out the window. It tells you that there is an inflammation, but it doesn't tell you where it's at. An important thing is urinary beta-HCG, which distinguishes between ectopic pregnancy and appendicitis. As we know, ectopic pregnancy can almost mirror the symptoms of appendicitis. And so based on the pain. So we really need to know if the patient is pregnant, and if the patient is pregnant, then a possible ectopic pregnancy cannot be overlooked. It has to be actually looked at, because this could be a case as well. So now we come to CT abdomen pelvis. Studies have demonstrated that CT has a high sensitivity, 98 to 98.5% of accurately diagnosing acute appendicitis. The question here is, how do you actually perform a CT abdomen pelvis? Is it solely without contrast, or is it with oral contrast, or is it with IV only, or is it with both? Every physician seems to have a different method for wanting to look at appendicitis. I've had some physicians, especially through the ER, just say, run the patient through without contrast, and let's just look at it, send it off for a reading, and let's get a report back, and if we need to go further, we will. But if we can get it diagnosed without contrast, we've saved the patient some time, and we can actually get them off to surgery. Others have said that they want IV contrast to really show out inflammation, to target the inflammatory process, and also to target the bowel wall. Some others have recommended oral contrast to kind of demonstrate, but the one thing that we always run into problem with people who actually have appendicitis is that they really don't want to drink. Drinking is something that they're just really having an aversion to at the moment. And so getting the oral contrast down sometimes is a very long and grueling process on both the patient and the tech. And we also find that some physicians want both oral and IV to best demonstrate. So it's really at the discretion of the physician, and many appendicitis protocols really vary based on the physician. And so that brings us to ultrasound. Because of concerns about patient exposure to radiation in relation to CT, ultrasound has gained some prominence. Ultrasound cannot view a normal, healthy appendix. So typically if you have a normal, healthy appendix, you won't be able to find it on ultrasound. Many studies have suggested that ultrasound be used for confirmation, but not exclusion. And so what many times physicians are kind of gravitating towards now is ordering an abdomen pelvis CT. And then once it's confirmed on CT, to actually order an ultrasound to confirm the confirmation on CT. However, for exclusion of appendicitis, you have to use CT. There is no other method for it. Ultrasound just is not accurate for that. So what does appendicitis actually look like on CT? Typically we find a distended appendix greater than 6 millimeters in diameter. And so when we're talking about diameter, keep in mind the appendix is going to look something like this on our axial images. And it has to be greater than 6 millimeters here. Or here. And so one way or another we have to have greater than 6 millimeters. We also see that we have thickened walls that enhance. And so typically what you're also going to see is that you have a degree of enhancement surrounding the appendix. So you're going to have the lumen here, and then you're going to have the walls, and you're going to have a very thickened wall that really enhances. And also straining in the right lower quadrant. So if this is the appendix here in this drawing, then you're going to have like little strands coming off of it to kind of point towards the inflammation. Also, an appendicolith may be seen, which will verify that the structure is the appendix. However, they're not always visible. So a lot of people get caught up in that they got to look for an appendicolith, but many times there isn't one to actually denote that the structure is the appendicitis. Remember we said that a fecalith becomes trapped and causes really inflammation in the appendix and eventually leads to appendicitis. Well, that's not always the case here. As we saw, there are other things that can actually happen that cause appendicitis. And so we can't always look for an appendicolith to be there and really denote the structure. So here is a classic case of appendicitis. As we can see that the structure really is very apparent here. We do see that we have a thickened wall around here, and if we're presuming that the entire structure from here to here is the appendix, then we also see that this is very dilated here and potentially here as well. And so obviously that this is appendicitis, and this could possibly be some stranding here. And we do see that we have air here, which we're really not getting a good idea of what the etiology is for that air. Hopefully it's not a perforated appendix, but we really can't tell from this solitary image. Here is another demonstration of appendicitis, where this large white arrow is pointing. This is the appendix. And as you can see, we have the lumen on the inside, and basically the walls of it are very thick. And as we can tell, we've got the external and internal iliacs here. And we can tell. So in this image, we have really what is a very indicative case of appendicitis. where the large white arrow is, we have the appendix. And another thing to keep in mind on all these images, the appendix really varies in location. Everyone's is going to be in the right lower quadrant, but it doesn't necessarily mean that they're going to be in the same location. Some can be very lateral, some can be medial. In this case, it's a very medial type of appendix, and it kind of varies with patient body habitus as well, to where your larger and smaller patients really differentiate on where the location of the appendix is. But back to this image, we actually have the appendix viewed. We see a very thickened wall. We can look around that we have oral contrast here, and we have IV contrast in the internal and external iliacs. And so this patient has been given all of these. Another important thing to remember is that if you're doing oral contrast on a patient who has possibly appendicitis, you don't know whether that patient has a ruptured appendix, so it's very important that you actually use water-soluble contrast as well. And I think that kind of goes without saying. But there is additionally on this image an arrow pointing over to the lateral border here, which potentially could be some degree of inflammation. But as we can see, if we measured the diameter of this appendix, we would have probably around 10 millimeter diameter. And so because of that, we would actually see that this person does have appendicitis. We'd also expect lab values to come back with an elevated white blood cell count, things like that. So it's very important that we kind of piece everything together. This image, this is probably the most impressive images of appendicitis here. We see that we have the cecum here, the ascending colon here, and coming right off of it we have the appendix. And I'm sure, as everyone can tell, this appendix is huge. And not only do we have appendix here, we do have some stranding coming off of it here. And because of that, we do say that this person definitely does have appendicitis. And if we look around, the patient has oral contrast here, IV contrast here, and so we kind of hit them with both of these as well. But this is a very large appendix. Sometimes, just to kind of give you a heads up, sometimes the appendix can be better seen on the coronal images. Sometimes the axial images kind of make everything run together, but the coronal images kind of allow separation of structures and can kind of really allow us to see that. So very important here to be able to distinguish the appendix. And as we can see, this patient's appendix is more on the lateral border of the right side and not medial right around here. Here's another image of appendicitis. Once again, this has both oral and IV contrast, as we can tell by the aorta, and some contrast return on the inferior vena cava. We do see that with a large arrow, we do see that we have the appendix here, and it is very dilated, and it does have a small portion of air there. Really not sure what's going on there, but it is very dilated. We do have some degree of stranding coming off of this, not quite as acute as the previous image that we saw. However, still appendicitis. One thing I want you to keep in mind here is that on the previous two images, we saw the appendix actually running down towards the bladder. On this patient, though, we see that the appendix is probably at the level of the kidneys. We got the left kidney coming in, got the right kidney getting ready too. And so based on that, we say that we're probably around L1, and so L1 or L2. And so very interesting to see the location of patient's appendix and seeing how they really vary. Also, I noticed the location on this is not completely as lateral, but it's almost between the lateral and the medial. And so I guess you'd say it's pretty much half and half in regards to that. But also take notice that this patient has a large amount of subcutaneous fat, and because of that, that can affect how the patient's appendix actually is based on body habitus, and based on subcutaneous fat and intraperitoneal fat as well. So that all affects where the appendix is located.
Okay, usually MRI is not used to diagnose appendicitis. There's many studies that report that only in pregnant ladies where you're looking for appendicitis should MRI actually be used in place of CT, because CT is readily available and it can be accomplished very quickly. However, we see that we have the appendix here. We're not really told if this is appendicitis or not. The easy thing about appendicitis is measuring the diameter of the appendix to see if it's within normal limits. We really don't get an indication of if this is within normal limits or not. But this is the appendix.
So that brings us to Crohn's disease. Crohn's disease is an idiopathic, chronic, transmural inflammatory process of the bowel that often leads to fibrosis and obstructive symptoms and can affect any part of the gastrointestinal tract from the mouth to the anus. So keep that in mind, that it can affect basically all parts of the gastrointestinal tract from the mouth to the anus. This condition is believed to be the result of an imbalance between the pro-inflammatory and anti-inflammatory mediators. Approximately 30% of Crohn's disease cases involve the small bowel, particularly the terminal ileum. Another 30% involve only the colon, and 40% involve both the small bowel and the colon. So keep that in mind, 30% only small bowel, 30% involve only the colon, and the higher majority of the cases actually involve both the small bowel and the large bowel. The granulomatous inflammatory process in Crohn's disease is frequently discontinuous, with the disease segments of bowel separated by apparently healthy portions, and these areas are known as skip areas or skip lesions. So that's something to keep in mind, that Crohn's disease has skip lesions. So you have diseased and healthy portions coinciding. That will become important when we actually look at colitis. The clinical spectrum of Crohn's disease is broad, ranging from relatively benign course with unpredictable acute attacks and remissions to severe diarrhea and an acute condition in the abdomen. So basically, it can take two courses of action. You can either have sometimes acute cases and then followed by periods of remission where things don't bother you and then flare up again, or you can just pretty much always have an active Crohn's disease. Most cases begin before age 30, and approximately 20 to 30% of all patients with Crohn's disease are diagnosed before the age of 20. So it starts with an early diagnosis, and then it starts with an early onset at 30 years of age. The prevalence of Crohn's disease in the United States is approximately 7 cases per 100,000 people, and so Crohn's disease is not quite as prominent as some of the other things that we've looked at. However, it does still have its prevalence among people in the United States. So what causes Crohn's disease? The exact cause of Crohn's disease is really unknown. However, it's believed to be associated with certain factors such as genetic, microbial, immunological, environmental, dietary, vascular, and psychosocial factors such as smoking, oral contraceptives, NSAIDs, stress. So pretty much a lot of things can contribute to the possibility of developing Crohn's disease. However, one of the big things is genetic. So pretty much you're born with the factors that can lead to Crohn's disease, and what we really don't know is if you're born with these factors, and you only need other mitigating factors to actually set it off, such as the psychosocial or the dietary or vascular or microbial. Smoking has been demonstrated to double the risk of Crohn's disease. One thing is that smoking, as we'll find out, has a lot of problem, or can raise a lot of problems. And so we definitely want to make note that smoking will double your risk of Crohn's disease. So very important to keep in mind. There is a strong correlation for a genetic predisposition suggesting inheritance. So if a family member has Crohn's disease or is a potential carrier for Crohn's disease, then that automatically increases your risk of developing Crohn's disease. So the symptoms of Crohn's disease. Possible symptoms are diffuse abdominal tenderness, severe diarrhea, blood in the stool, and right lower quadrant pain, mimicking that of appendicitis. Important to keep in mind that not everyone who complains of right lower quadrant pain has appendicitis, as we saw, that 1.1 people per 1,000 have appendicitis. And so it could potentially be Crohn's disease as well. So the way that we actually find out if a patient has Crohn's disease, it first begins with lab tests. This is a CBC metabolic panel. And we look for hypoalbuminemia to be common. We also take a stool sample to look and see if there's blood in the stool. CT abdomen pelvis, MRI, ultrasound, and colonoscopy all have various advantages and disadvantages, and each can be employed to a certain degree. Also, colonoscopy still remains a very, very good example here because it allows you to actually see what is going on with the camera, and then also provide some degree of interventional and diagnostic means while you're in there, so just taking biopsies and things like that. So colonoscopy still remains almost a gold standard for things such as Crohn's disease. So what does it look like on CT? Typically you're going to see circumferential thickening of the bowel wall as being the hallmark of the disease. Thickening is most often 1 to 2 centimeters, but can be up to 3 centimeters. So you're going to look for bowel wall thickening. The presence of skip lesions is another hallmark of the disease. So let's look for skip lesions as well. It means that all of the bowel is not affected. And so this means that basically there's going to be diseased portions of the bowel next to good portions of the bowel. Fistulas and sinus tracts between bowel loops or to the bladder, adjacent muscle, or the skin surfaces are characteristic as well. And so basically you're going to look for transition points that should not exist between bowel and other things such as bladder, muscle, skin, or even other bowel loops. So that's what we're going to look for as well. But the most common is, once again, skip lesions. Another thing to keep in mind here is that we have normal bowel here. As we can see, the wall is not thickened and it's very normal, as is the bowel here and here. But we also see that we have another portion of the bowel there. And as we can see, the bowel wall is also thickened, not to the degree that where the red circle is, that portion of the bowel, but still it's thickened nonetheless. And so based on this, we see that we have the presence of skip lesions. And so all of this, where the yellow circle is, will be defined as a skip lesion. And we do have 2 portions of Crohn's here. Here's another portion. We have thickening here, here. Let me erase that. Kind of here, here. And so we have 3 points of thickening. So keep that in your frame of reference. And then we have normal portions of bowel here. And so because of that, we have skip lesions. And once again, skip lesions are going to be what really defines Crohn's disease and really separates it from colitis. Because Crohn's disease, you don't have all of the bowel affected. And so that's something to keep in mind and will help you as you're looking at CTs and trying to define what is actually going on based on the patient's symptoms and what you're seeing on the images. So that brings us to colitis. Colitis is an inflammation of the colon, and it can be associated with enteritis, which is the inflammation of the intestine, or proctitis, which is inflammation of the rectum. It's one of 2 disease processes labeled as inflammatory bowel disease, with the other being Crohn's disease. So keep that in mind. Inflammatory bowel disease, you'll hear that kind of tossed around, means Crohn's or colitis. Those are 2 diseases that are actually defined as inflammatory. We see that there are certain types of colitis. We have ulcerative colitis, Crohn's colitis, pseudomembranous colitis, typhlitis, ischemic colitis, radiation colitis, and toxic megacolon. We see ulcerative colitis is described as a variable in severity, characterized by inflammation and diffuse ulceration of the colon mucosa. Crohn's colitis is characterized by transmural inflammation that usually affects the terminal ileum and proximal colon, greater bowel wall thickening. So keep that in mind. Crohn's colitis affects terminal ileum and proximal colon. Pseudomembranous colitis results from overgrowth of Clostridium difficile, or C. diff, in the colon as a complication of antibiotic therapy. And so you'll see patients actually take C. diffs, or doctors order C. diffs on patients, and that's what we're actually looking for, an abnormality in the C differential. Typhlitis is a potentially fatal infection of the cecum and ascending colon in patients who are neutropenic and severely immunocompromised. And so typhlitis results in, or takes precedence in, immunocompromised patients. Ischemic colitis is a type of colitis that occurs with low cardiac output. So ischemic colitis is caused by the bowel not receiving enough blood due to low cardiac output. Radiation colitis is thickening of the bowel wall in the area that is receiving radiation therapy. So it's due to radiation therapy. Toxic megacolon is a complication of many types of colitis and potentially fatal. And so you combine several forms of colitis and you get toxic megacolon. And so it's very, very deadly. But just keep what we have highlighted here to kind of keep it straight on what type of colitis you may be actually viewing. So what causes colitis? It can be caused by acute infections, hypersensitivity to various allergens, ischemia, and vasculitis, as we saw in the previous. So patients who have colitis typically present with abdominal distension, diffuse tenderness, blood and mucus in the stool, and diarrhea with blood in the stool. And so if we'll notice here, typically you're going to see some blood in the stool, and this is really indicative of colitis, and mixed with mucus due to the inflammation and the inflammatory processes that might be actually occurring. But you do see patients come in with very distended abdomens and very tender. They feel like they're bloated, but it goes far beyond being bloated. And when you press on their abdomen, they are very, very sore, very tender. They don't want you to touch it. They don't want to be pressed on. They don't want to, honestly, lie in any position that would cause them to put pressure on their abdomen. So very, very painful. So how do we actually diagnose colitis. First, begin with laboratory tests as well. CBC look for elevated white blood cell counts and things that would be indicative of inflammation. CRP levels, as we've already talked about, C-reactive protein is elevated in 90% of the cases. But once again, as we've discussed, the CRP does not actually distinguish between areas of inflammation, and so it really can't tell you the difference between anything. It just tells you that there's an inflammation going on. Metabolic panel, just to see if there's any abnormalities, dehydration, things like that. Also, I typically going to look for C. difficile levels, just to see if, due to antibiotic therapy, if this level has increased and caused colitis. Also, we're going to potentially do a CT abdomen pelvis. Abdominal films such as flat and upright really are not indicative of anything here and cannot help and aid in the diagnosis. CT abdomen pelvis really can, and as we'll see, looks almost similar to Crohn's disease, but not quite. An MRI, much the same way that CT can perform this, MRI can as well. However, in patients who typically may need an immediate diagnosis very rapidly, in case there's something else going on, CT offers a better and more advantageous area in this. So as we see, colitis has different manifestations. If we first begin with ulcerative colitis, we see that bowel wall thickening with lumen narrowing. So almost looking the same way that we saw with Crohn's disease. Thickening is usually in the range of 7 to 8 millimeters, so not quite as much as what Crohn's disease has. Crohn's colitis, we see that we have bowel wall thickening of 10 to 20 millimeters, so 1 to 2 centimeters, virtually mirroring what Crohn's actually looks like. We see that the outer wall is irregular. It's not nice, smooth, rounded, but it's kind of a little different shape and size. Pseudomembranous colitis, segmental with irregular wall thickening. Thickening can be up to 30 millimeters, and so basically 3 centimeters. Typhlitis, a wall thickening of 10 to 30 millimeters. Low density edema with cecal wall and pericecal fluid and inflammation. Ischemic colitis, mild to moderate circumferential thickening and a segment of colon corresponding to an anatomic vascular distribution. And toxic megacolon, dilatation of the colon greater than 5 centimeters. Thinning of the wall, and possibly perforation. And so basically we're going to be concerned with ulcerative, Crohn's, and toxic megacolon, because those are going to be the ones that you're really going to see a lot of. So here we have a demonstration of colitis. We see that we have bowel wall thickening where the white arrows are. And then we do have some degree of narrowing here for the lumen. But also, if we look at the generalized area here, we see that we have IV contrast, and we do see that the bowel wall is slightly thickened. We do see dilation of the bowel, but we also see bowel wall thickening slightly. It's not the same type as Crohn's disease, where you have these huge thickened areas of bowel, but this is very very tiny. But due to the fact that we have IV contrast here, we know that we actually have the wall absorbing some of the contrast and kind of highlighting and standing out. So we have a degree of colitis here. So the important thing to look for between Crohn's and colitis is really what happens. Crohn's disease is going to be located in the entire digestive tract. So, as we saw before, it can go from the mouth to the anus. Colitis, however, on the other hand, is only large bowel. So you're only going to look for colitis in the large intestine. The pain location for Crohn's disease is the right lower quadrant. Colitis is left lower quadrant. Manifestation, we see that Crohn's disease is really patchy with the presence of skip lesions. Colitis has no skip lesions, so wherever it begins, it's going to run its full course, and that'll be the only area that you see colitis in. There won't be bits and pieces here and there. There's no skip lesions. In complication, with Crohn's disease, we have fistulas and strictures, and colitis really doesn't have as many of those complications. We just have inflammation of the bowel. And so these are the things to really keep in mind. And when you actually look at it on CT, just kind of try and piece things together. And for the sake of the exam, I will give you a pretty decent amount of heads up about the patient, such as this patient presents with right lower quadrant pain. What does this image appear to be demonstrating? And so it'll be pretty easy to actually demonstrate here and for you to actually distinguish. So esophageal carcinoma. Historically, esophageal carcinoma has been well described since the beginning of the 19th century. Most carcinomas of the esophagus are of the squamous cell type, and they occur most often in the esophagastric junction. In the U.S., for the year 2008, the American Cancer Society estimated 16,470 new cases, 12,970 men versus 3,500 women, with 14,280 expected to die of the disease. And so, if we look at that, we see that 14,000 of the 16,000 are expected to die of this disease. Also, take notice that there are more men than women that are affected by this. The mortality rate is then 87%. The incidence is far higher among men than women. So chances are, if you have esophageal carcinoma, your prognosis is not very good. It's going to be almost a very dire situation. So what causes esophageal carcinoma? Evidence has suggested that the following increase the likelihood of esophageal carcinoma: cigarette smoke, excessive alcohol intake. Interesting, for people who drink more than 30 grams of alcohol per day when compared to those who don't, there's a 4-to-1 ratio of developing esophageal carcinoma. For people who drink more than 15 grams of alcohol per day and smoke when compared to those who don't, there's an 8-to-1 ratio. And so it's very interesting here that if you consume more alcohol but you don't smoke, you're increasing it fourfold. However, if you drink less alcohol, if you cut your alcohol consumption in half, but then you smoke, you double the risk of what just drinking alcohol would do. So it's very important to note that smoking does not only harm the lungs, but it also can lead to other things such as esophageal carcinoma. And that's kind of bore out by these facts, where drinking less but smoking really increases the amount. Also, HPV, or the human papillomavirus, can somehow increase esophageal carcinoma or the risk for it. So esophageal carcinoma is associated with dysphagia, weight loss, which occurs in more than 50% of the patients, pain or pressure in the epigastric or retrosternal area, hoarseness, cough. One of the big clear indicating factors here is dysphagia. where you're chewing your food, you're trying to get it down, and you just keep on feeling like it's stuck and you can't get it down. There's nothing that you can do, and it takes it forever to actually go down. And that's pretty indicative of there actually being carcinoma, creating almost a stenosis there, to where food is not able to actually get down where it should. So the workup for diagnosis. Lab tests are not typically used to diagnose, but rather to look at the effects of esophageal carcinoma. We can do a barium swallow, and typically this is very good to really distinguish what is going on. An endoscopic ultrasound, bronchoscopy, and then a CT of the neck and chest. Bronchoscopy and barium swallow are very indicative. Usually a barium swallow will show a stricture going in, and it's only left to presume what that stricture is caused by. And then bronchoscopy actually allows you to view this, or an EGD will allow you to do this as well. CT of the neck, chest is used to assess the extent of the disease and to identify those patients for whom the disease cannot be resected. And so basically, CT is used to kind of plan everything out and to make sure that because there is a known carcinoma there, that this carcinoma has not actually metastasized into the lungs, or it's coming from the lungs and working its way up the esophagus. So CT is used for more of a planning procedure than anything else in this case. that brings us to gastric carcinoma. Gastric cancer was once the second most common cancer in the world. In most developed countries, however, rates of stomach cancer have declined dramatically over the past century. In the United States, stomach malignancy is currently the 14th most common cancer. Decreases in gastric cancer have been attributed in part to widespread use of refrigeration, which has had several beneficial effects, such as increased consumption of fresh fruits and vegetables, decreased intake of salt, which had been used as a food preservative, and decreased contamination of food by carcinogenic compounds arising from the decay of unrefrigerated meat products. Basically, this decrease in gastric cancer has basically been a result of modernization of the way that we handle food and our diets. So the workup for diagnosis for gastric carcinoma is pretty simple. We have lab tests such as CBC, cancer antigen, but it's only elevated in 20% of the cases. EGD, chest X-ray to evaluate for METs, CT chest, abdomen, pelvis, and MRI. So the way that it looks on CT, the primary tumor appears as a focal, nodular, or irregular thickening of the gastric wall. Diffuse wall thickening with narrowing of the lumen. And so we have stage 1, stage 2, stage 3, and stage 4. Stage 1, we see that we have an intraluminal mass without wall thickening. Stage 2, we have wall thickening greater than 1 centimeter without invasion of other tissues. So we see that there's something going on with the stomach, but it's not in anything else. Stage 3 is wall thickening with invasion of other organs. So we've not only progressed from the gastric carcinoma, but we've also metastasized into other areas. And stage 4 is obliteration of the fat planes that cover the stomach. So basically, the stomach becomes one huge mass that really cannot be delineated from anything else. So here we have our first example of gastric carcinoma. We said that we have a narrowing here, pretty much thickening of the wall of the stomach. And so this is our mass here, creating a very narrowing effect. And so it would probably be safe to assume that this is stage 1. Not really horrible, and so this is a very good case for the patient, so that the patient can actually probably recover very well from this. This is probably stage 1 as well. Notice where the black arrow is. It's simply in the stomach, but nothing else. So potentially stage 1 as well. However, the case can be argued based on measurements that this could be stage 2. However, we would have to wait and see what the measurements actually define. So let's say that we will be safe to say stage 1 or 2. And now we pretty much ramp everything up and get to stage 4. This is the stomach, even though it really doesn't look like it. And we have pretty much mass here, 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 here. And it's probably safe to say that we have it in other organs as well. We've passed the liver. We're getting into the lower borders of the liver. So it's really, we're unable to see this. But the really scary thing about this is the amount of discomfort that the patient has to be feeling. If we actually look at what, this is presumably the body of the stomach. And this area here is all the room that we have for the stomach contents, because the bowel wall has actually been invaded, and so all the fat planes have been obliterated, and there's really nothing left here but just a small portion for food to pass through. Based on this findings here, I would say that it would be safe to assume that this patient has a very poor prognosis, being in stage 4, and probably not much in the way of surgical intervention that could be done here. So colon cancer. Carcinoma of the colon and rectum is the third leading cause of death from cancer in the United States. About half of colon carcinomas occur in the rectum and sigmoid, where they can be felt by rectal examination or seen with a sigmoidoscope. Colon cancer spreads by direct extension with penetration of the colon wall, lymphatic drainage to regional nodes, hematogenous routes through the portal veins to the liver, intraperitoneal seeding. So there's a variety of ways that colon cancer can actually spread, and once colon cancer spreads, then it is anybody's guess what the prognosis could be for the patient. So the cause of colon cancer is really kind of up in the air, but there are certain things that we feel that predispose patients to cancer of the colon. Number one is long-standing ulcerative colitis. So the inflammation of the colon over and over and over and over again tend to elevate the risk of colon cancer. Also, familial polyposis, which is a hereditary disease in which innumerable polyps develop in the colon and elsewhere in the intestinal tract. And so, as we all, I'm sure, have had people that are close to us have colonoscopy and have biopsies of polyps. And so that's what we're actually looking at. Some of these polyps can actually turn into cancer, and because of that, familial polyposis is something that we're looking at and worrying about these polyps actually turning into something that are worse than what they really are. So it's very important to keep a watch on these. So the symptoms of colon cancer are fatigue, weight loss, abdominal tenderness, rectal bleeding, and a palpable abdominal mass. Typically we look for weight loss and fatigue, and even some rectal bleeding as being the primary symptoms of colon cancer, the things that really stand out to us as being diagnostic in quality. So the way that colon cancer can be worked up for diagnosis is, number one, a rectal examination. As we saw in some of the facts that colon cancer can be felt by basically a physician palpating for this mass through a rectal examination. Also colonoscopy. Colonoscopy is very indicative. It allows you to biopsy polyps as well as see if there are any apple core lesions. However, I have seen several times where physicians haven't been able to do a full colonoscopy simply because of a mass, which leads to other things such as barium enemas, CT abdomen pelvises, and MRIs. Typically, it used to be that barium enemas were the favored exam. However, now with the many things that we can do with CT and provide adequate imaging, CT abdomen pelvises kind of gain precedence here. Many times physicians order the CT abdomen pelvises with rectal contrast, which is carried out in much the same fashion that the barium enema is, except that many times barium is not used. It is water-soluble contrast in case of perforation, and allows you to really demonstrate the patient's lower portion of their colon very adequately. So what it looks like on CT is quite simple. The primary tumor may be a colon polyp. These are nearly always larger than 1 centimeter. So you're looking for a polyp that is greater than 1 centimeter. Most cancers appear as a soft tissue mass that narrows the lumen of the colon. Apple core lesions demonstrate irregular, bulky, circumferential wall thickening with a marked and irregular narrowing of the bowel lumen. Regional lymph nodes larger than 1 centimeter are considered positive for metastatic disease. But many times what we're looking for is an apple core lesion, which narrows the lumen. And what we are defining as an apple core lesion is something like this, with this being masses and this being the lumen here, and see how the lumen is virtually narrowed from basically what it could be here. And so that's what we're typically looking for in terms of an apple core lesion. And the reason it's called apple core lesion is because it looks like an apple that has been ate. So here we see a coronal image. We have what we're labeling here as the rectus sigmoid. And we're going to say that this is close to the rectum here. And so we see that we have bowel coming in and bowel coming out, but this huge abnormality here. And this is classic apple core lesion when you have gross thickening here and here, creating a very small lumen for intestinal contents to actually move through. Here's another example where the blue arrow is pointing of an axial image on a patient that has potentially colon cancer. We do see that we have what looks to be an apple core lesion. It's not quite as impressive here as it is on other views such as coronal and sagittal, because you really don't get to see the full extent as you go down slice by slice. But we do see that we have increased thickening of the bowel wall here and here, and narrowing of the lumen. Probably not quite as much as previous image, but still enough to cause disruption of the intestinal contents. Metastasis. Metastasis to the bowel wall or bowel are rare and almost always impossible to differentiate from primary tumors. When they do occur, it stems from such things as melanoma or renal cell carcinoma. Which brings us to abdominal tumors. Tumors of the small bowel are very rare. 4% of all intestinal tumors. 75% of all small bowel tumors are benign. The most common benign tumor of the small bowel is the leiomyoma, which typically involves the jejunum. The most common benign tumor of the colon are adenomas or polyps and lipomas. The risk of malignant transformation in adenomas depends on the size and histology of the tumor. Polyps greater than 1 centimeter in size have a higher risk of malignancy. So once again, we refer back to the polyps. As we see, most polyps are benign. However, there are those instances where those polyps can transform from being benign to malignant. So something to keep in mind as the polyp grows, the chance of malignancy skyrockets. So here are some polyps taken from an endoscopy or a colonoscopy. And this is polyps here. And so if we refer to this image here, we see that it's almost at the hepatic flexure, where it's actually going and bridging between the hepatic flexure and the transverse colon. So this brings us to abdominal trauma. Injuries to the bowel and mesentery occur in about 5% of patients after blunt abdominal trauma. Accuracy of CT and diagnosis of bowel and mesentery injuries is reported to be around 77 to 95%. Patients who are hemodynamically stable are those that are good candidates for CT. So patients that are brought in from abdominal trauma or trauma in general, those that are stable are good candidates for CT. However, patients who are hemodynamically unstable, have signs of peritonitis, or have had penetrating abdominal trauma should be taken for emergency exploratory surgery. This should not be delayed to take the patients to CT. Even though we have increased the amount of speed that we perform CT examinations with, and we've almost got it down to a science on how to actually handle patients, it still is no substitution for getting the patient from the emergency room to exploratory surgery where the patient can be hopefully stabilized. Because CT, while it will aid in the diagnosis, sometimes is not necessary to actually save the patient's life. So it's more important to save the patient's life than to have the patient taken to a CT room for even just a small amount of time. So here we have In this image, it's very hard to see. If we had switched to lung windows to where we could actually pick out air, it would be much better. But we do see that we have what looks to be some free air here, and that's usually due to a bowel perforation. And so that's one example of trauma in the abdomen. And so you're typically going to look for free air, perforations, things like that, so that you can actually really diagnose abdominal trauma. But one thing to keep in mind for abdominal trauma is that you typically want to perform the exams and with the standard window levels, but then on your reconstructions, you would also like to do a reconstruction that has simply lung windows to look for free air that is actually going up in the patient. And as we would see, it would go to the anterior portion if the patient is laying on their back, which in this case they are. Here's another image of abdominal trauma. Notice how all the bowel loops are really dilated. And so all of this dilation is due to the trauma that has actually been inflicted. And as we can see, this is a very small patient, very, very tiny. And so based on that, this is what sometimes abdominal trauma will look like as well. And we see that kind of on this patient as well. The patient has a history of abdominal trauma, and we have dilated bowel loops. Also, we see that the patient is not laying completely flat on the table. The patient is actually laying in a plane, something like this. However, that really doesn't affect the amount of trauma that's really designated and demonstrated here. We just see that there is dilated bowel loops. Almost makes you think of an intestinal blockage in terms of the small bowel. However, based on the patient's history of trauma and things like that, we actually see that we have intestinal dilation. Also, we have something metallic inside the abdominal area. Really unsure what this is at the moment. We would have to see the other portions of the scan to really demonstrate this and understand it. But know that one of the many things, or the many signs of abdominal trauma or serious abdominal trauma, is dilation of the bowel.